Can you give an example of the kinds of suboptimal care that you found that older adults are getting?
I think there's lack of awareness just about how big the problem is. I think people get overwhelmed. I think there might be nihilism, like, oh, this is so big, there's not much we can do about it. I think there's also a lot of ageism in the system, like, oh, you're just getting old, and not realizing that, being frail or sick is not synonymous with aging. And I think there's also a lack of awareness of the return on investment for getting this right. We do have a lot of evidence for solutions. What we don't have is the evidence is how do we make these mainstream and how do we scale them? If you could extend active life expectancy, so your years without disability, by 1 year, it's worth $37 trillion a year to the US economy. So that we can make the case for doing that. I think we need to figure out how to educate people about the opportunity that's here.
What are the kinds of avoidable adverse events that you've seen? I know you said morbidity and mortality, but could you be like a little bit more specific and give us an example that we can apply to real life?
Polypharmacy is a big problem. And, people's also physiology changes as they get older. So there's also drugs that have like more adverse side effects in older adults than younger adults that should be avoided. But because people have multiple diseases, people often take 10, 12 drugs, it's called polypharmacy. And there's drug interactions and side effects. And there's also something called prescribing cascade, where you're given a drug for something, it causes a side effect. And rather than stopping the drug, you're given another drug to treat the side effect of the first drug. And so this is to give, interdisciplinary teams and practices the time to sit down and talk to people and say, what do you want to achieve and how can I help you achieve it? And tailor shared care planning so that the care you're getting really helps you meet your needs.
What needs re-engineering? Like, what are we doing now that needs to be re-engineered?
Number one, we need to invest in primary care. I mean, if we talk about evidence, systems that are based in primary care have, better health outcomes, improved access, better quality of life. And our primary care system in the US is really on life support right now, and that's central. You need a primary care doc who can help coordinate all your health needs. If we have a life course approach that integrates public health and primary care, that focuses on prevention, better chronic disease management, we could really make the population much healthier as it ages.
You mentioned some of the new codes. Some of the things that CMS has started to pay for are about social determinants of health, like a needs assessment. Can you tell us a little bit more about, I understand AHRQ has a social determinants of health database. You mentioned what you're doing on social. How does that all connect to, this opportunity for physicians to bill for doing an assessment for social determinants of health needs?
Our social determinants of health database is a very valuable resource, and it's national, and you could drill down to local levels. And it gives you, so you could do area level work, understanding the needs of different communities, and it's easy to link it onto any data set. So that's the other thing that AHRQ does that I didn't mention, is it provides a lot of data for analysis. There's a huge social safety net out there that health systems don't have to recreate, but they need to know that it's there and access it. So part of this is education, not for healthcare to start making the capacity, but to know, what's in their systems.
CMS recently announced or proposed in their hospital outpatient department proposed rule, a program that would essentially pay more for the use of non-opioid alternatives, but it's limited currently by Congress to post-operative pain. I know your focus has been chronic pain. Are there ideas like that AHRQ looks into to see if they think, well, okay, the cheapest thing in the world to do is prescribe an opioid because they're all generics, anything that's made that's a non-opioid alternative probably costs more than an opioid. So when we look at costs in that sense, it seems like it's going to cost some money to avoid opioid use, and not just for post-operative pain, but also for chronic pain.
I'm not sure you could say it's cheaper, because in the long run, you have the complications. If you're on opioids and you have a fall and break your hip, well, that's pretty expensive. If you have on opioids and you have some mild cognitive impairment and you get confused and you forget to take your heart failure meds and end up in the hospital for, decompensated heart failure, that's expensive. So I think we need to really think about what are the costs. And also, what are the costs in terms of quality of life and people being able to engage? When do we get value because we're improving quality of life?
What are some of the key needs of older adults and their families that that's a result of the mismatch that AHRQ identified?
I'll give you an example. So, if somebody has chronic kidney disease and heart failure, which is a very common combination, they might go to their cardiologist who says, you know what, you really should restrict your fluids because you don't want to be, your legs to swell, you don't want to get fluid overloaded, you don't want to get into failure. And they go, okay. And then they go to their nephrologist and says, you know what, you have kidney problems. You need to drink enough fluid to perfuse those kidneys. So what does a poor person do? And how do we make a plan that puts that together and balances the need for, perfusing the kidneys and not being too fluid overloaded? So I think that's, with technology, with our e-care plan, everybody, the primary care doctor, specialists can all have access to all that integrated information and have a conversation for this one patient. What is the best balance of these things, but also the patient's goals and their priorities?
I noticed that the gap in health disparities, and both racially, ethnically, and economically, seems to be widening. Why is it widening when more people have access to health insurance than ever before?
That's $1 million question. I'm not sure I don't know that there's one answer to that. It's probably multifactorial. But I do think that our system is failing to meet the needs or prioritize the things that would improve health. And I think there's simple things that can do that are actually not that costly, that could have a huge return on investment. One of them I mentioned before is strengthening primary care. The other is really integrating, public health and primary care. And a good example of that is we've been successful a lot in smoking cessation. There's still disparities. Actually, AHRQ has the Prevention Task Force app that anybody could download. As a matter of fact, I went for a checkup and, they said, do you mind if the resident sees you? And of course, a former, faculty, I said, yeah, that's okay. She came in and she had the task force app to see what preventive services I need. But people could download that too. And when you go to your doctor, you could decide which are the ones that you want. And if you put in your age and sex, it'll tell you, what services are recommended now. There is a science of care that we need to figure out. We have the science of what works to treat each diseases, but there's also a whole science on how to deliver healthcare to be able to, optimize outcomes. And I think to realize the potential of that work and the necessity of that work,